Knee pain is a very common problem in all age groups. Over the age of 60, the pain is more likely to be caused by arthritis, but it can also be triggered by a tear in the cartilage, tear in the meniscus, or ligaments around the knee. It is important to understand that not all knee pain comes from the knee itself. Hip, spine, and other rheumatologic problems such as fibromyalgia can also cause knee pain. Your provider will work with you to determine which issues are most active and what the best solutions may be. Your provider will first ask you some basic health questions and specific questions about your knee. Based on your answers, your knee will be examined to determine its mobility and stability, and specific physical exam tests will be done to fine-tune the diagnosis. Your unaffected knee, lower back, and hip may also be examined. You may have come to the clinic with one or more diagnostic imaging tests, such as X-rays, ultrasound, or MRI ordered by your primary care provider. The findings in your reports may also be making you anxious. Let's talk about some of these diagnostic imaging tests and how we use them. Ultimately, at the clinic, your provider will determine if they have enough information from what has already been provided on referral, or if other tests are recommended. Although you may have come to the clinic with some X-rays of your knee, additional views may be needed. We get asked commonly about MRI of the knee. Most of the time, an MRI is not required to start treatment, but where there are many potential contributing factors or for planning surgery, an MRI scan may be ordered by your treatment team. We often see patients who have already had an MRI and are anxious about many abnormal findings. We use the history and physical examination to determine which, if any, may be responsible for your knee pain or are simply wear and tear. The same can be said for ultrasound. In general, ultrasound of the knee does not help with management and will only be ordered for very specific problems guided by your history and physical exam. We see many patients who have had an ultrasound on referral, but we rarely use the findings to make a treatment decision. We encourage you to watch the other videos in our series, including non-operative treatment of knee pain and injections, as they are applicable to this discussion. This is because, for mechanical sources of knee pain, including meniscal tears, some ligament tears, and also for arthritis, an operation is rarely the first step. Often, physiotherapy, bracing, or certain injections can be helpful to restore function, alleviate pain, and potentially avoid or delay an operation. Non-impact exercises such as cycling, swimming, elliptical trainer, rowing, and walking are generally safe to start. Impact activities such as running, jumping, and skipping should be avoided until advised to do so by your care provider. The knee has two rubbery cartilage discs called menisci, which act as shock absorbers. These soften and are more susceptible to wearing and tearing as we age. In general, tears of the meniscus can occur in all age groups, with or without trauma. We call wear and tear type tears degenerative, and they are often found on MRI or ultrasound. They are indicative of arthritis but don't always cause pain. In fact, most degenerative meniscus tears can be treated with a physiotherapy and pain management program. If pain persists despite this, arthroscopic knee surgery can be done to trim the torn part of the meniscus, which remains painful. Meniscus tears can also be caused by injury with or without previous degeneration. We call these traumatic meniscus tears. In certain circumstances, such as the inability to fully straighten the knee and some sports injuries, initial treatment with physiotherapy may be recommended. However, your doctor may ultimately recommend arthroscopic knee surgery to trim and/or repair these tears to prevent further injury and improve function. The anterior cruciate ligament, or ACL, can be injured following a plant and pivot type injury. This is a common injury amongst soccer, volleyball, rugby, football, and basketball players. Normally, this ligament helps to stabilize the knee during pivoting and sudden stops or starts when running. A traumatic meniscus tear can also occur with the same type of injury, and the ACL and torn meniscus rarely heal on their own. It can lead to knee swelling, pain, and a persistent instability or buckling knee. Based on your age, sport, and level of activity, non-operative treatments such as physiotherapy and bracing may be treatments. However, for most younger, highly active patients who play a pivoting sport, an arthroscopic ACL reconstruction may be recommended to treat knee instability and prevent further injury to cartilage or meniscus. In this operation, we use another tendon from your knee, such as the hamstrings, patellar tendon, or more recently, quadriceps tendon, to replace the torn ACL and restore stability. Pain in the front of the knee, just behind the kneecap, can also be associated with kneecap instability, inflammation, or wear and tear of the cartilage on the kneecap. This is known as patellofemoral syndrome. Treatment includes strengthening of the quadriceps muscle, sometimes along with bracing or taping of the kneecap. Riding a bicycle, rowing, and elliptical trainer use are good low-impact exercises. Rarely is surgery required for this. This video presents several causes for having knee pain. It is intended as a general guideline for what to expect during your assessment. We encourage you to ask questions regarding your specific activity restrictions and management plan at the time of your appointment.